Good morning and good afternoon. Everyone, welcome. We're very happy to have you here. Welcome to the Injury Prevention Visiting Scholars Collaborative. This is a partnership among the CDC Injury Control Research Centers at the University of Iowa, Johns Hopkins Bloomberg School of Public Health, and the University of Michigan. The purpose of this collaboration is to create an ongoing opportunity for early career faculty working in injury prevention to share their research with interdisciplinary teams beyond their home institutions. Leadership from each of our centers is here to have the opportunity to give an introduction. I will start by passing it to my colleague, Dr. Carrie Castile at the University of Iowa.
Thanks, Doug. Hi, I'm Carrie Castile, and I'm the director of the Injury Prevention Research Center at the University of Iowa. I also want to thank you all for attending the webinar today, and I really appreciate opportunities like this to collaborate with peer injury control research centers and also to support the up-and-coming injury and violence prevention researchers and practitioners. I'd like to thank and acknowledge the center leadership at the three injury control research centers who played key roles in advancing this initiative today, specifically Doug Wiebe, director, and Nicole Burnside, managing director of the University of Michigan Injury Prevention Center. Lisa Roth, who is the deputy director, and Kara Hamann, who is the director of training and education at the University of Iowa Injury Prevention Research Center. And also Shannon Frateroli and Renee Johnson. Shannon, who's the director, and Renee Johnson, who's the director of training and education at the Johns Hopkins Center for Injury Research and Policy. And I will hand it over to Shannon to introduce the speaker.
Thank you, Carrie, and welcome everybody to the first of a series of seminars that we're just thrilled to be launching here today. I really can't think of a better person to kick off this series than Dr. Natasha Oyedele. She has been here in Baltimore at Johns Hopkins for a number of years. She made her way down to us after her early undergraduate studies and master's studies were in Boston. And then she came to us for her PhD education and stayed, fortunately for us, to complete a postdoctoral degree with us under the direction of Dr. Renee Johnson. So we're thrilled to highlight Natasha's work here today. Her interests and contributions to our field have been in the area of structural racism, looking at different inequities associated with substance use and related problems. And I'm thrilled that she's going to be sharing with us today part of what she's doing for her postdoctoral work, which really focuses on an important aspect of adverse childhood experiences, or ACEs, by looking at what the possible contributions are with regard to later outcomes that come from unintentional injuries. It's not something that's really considered in the ACEs literature, but let's see what Natasha has to say about whether it should be moving forward. So, Dr. Oyedele, over to you.
Thank you so much. Good afternoon, everyone. My name is Natasha Oyedele. It's my pleasure to be here with you this afternoon. Many thanks to the injury centers at the University of Michigan, University of Iowa, and the Bloomberg School of Public Health for the opportunity to speak with you this afternoon. I'll be sharing my research focused on gender-specific examinations of adverse childhood experiences among Black Americans. So I'll structure my talk today by giving a brief introduction about myself, and then talk a little bit about my research on measuring ACEs in Black Americans, and then transition to making a case for unintentional injuries as an adverse childhood experience, and share a bit of my current research and proposed research. So I started my academic career at Wellesley College, where I studied biology and Africana studies. And then I transitioned to working as an infectious disease epidemiologist in Boston. and formally got my training in epidemiology at the Boston University School of Public Health. And then I worked as an applied epidemiologist for several years before continuing my education in the Department of Mental Health at the Bloomberg School of Public Health, focused on drug dependence epidemiology. And much of my dissertation research, as well as postdoctoral research, will be shared here today. My research interests are primarily focused on adverse childhood experiences and how those early traumatic experiences affect substance use later in life, including tobacco cigarette use. My research focus is undergirded by the principles of social epidemiology, which emphasize the social production of disease as an explanatory paradigm that affect health-related outcomes. The field of social epidemiology influences our understanding and approach to public health and adds empirical and theoretical contributions to the study of health and its determinants. Social epidemiology is incorporated in my work by focusing on the fundamental causes that impact ACEs and substance use and how the mechanistic pathways may look different for racialized populations. So I'll start with a brief overview of adverse childhood experiences. In this presentation, I'll refer to them as ACEs. They are defined as potentially traumatic childhood events that occur between the ages of 0 and 17 years, and it can include experiences of violence, abuse, neglect, or witnessing household violence. They have been shown in the literature to be linked to an increased risk of health risk behaviors in adulthood. And so the original ACE study, foundational ACE study by Folletti and colleagues demonstrated that individuals with 4 or more ACEs were significantly more likely to engage in behaviors, including smoking, heavy alcohol use, illicit drug use, and sexual risk behaviors compared to those with no ACEs. It's also been shown to be associated with unhealthy coping mechanisms and psychological distress. And so some degree of stress and adversity is a normal part of human development, but exposure to frequent and prolonged adversity, especially in the absence of protective factors, can result in toxic stress. And that's the prolonged activation of the body's stress response systems. And so behaviors we label as unhealthy coping, such as substance use, are often in individuals' maladaptive coping strategies. The literature also shows us that ACEs are inequitably distributed by racialized groups. Black children report exposure to multiple individual ACEs more than their white peers. And this may be due to a complex interplay of contextual factors, including differential exposure to structural factors and social disadvantage, which may negatively impact physical and mental well-being across the life course. And so this slide just gives us a list of some of the ACEs that are typically used in surveillance systems and surveys and some that are not. And so there are typically 10 foundational ACEs that are included, and those fall into the category of abuse. So both emotional, sexual, and physical abuse, as well as household challenges. The neglect category, where you see is emotional and physical, were added or began to be included in 2019 and rolled out in the 2020 Birthright Survey. And that's the survey that I used for my research. And so they won't be presented as a part of this research, but definitely have been included going forward. And then on the right side of the slide, you see that there are other adversities that are equally considered an adverse childhood experience, including bullying, community violence, natural disasters, and experiences with wartime or terrorism. And so the seminal research that established that ACEs are common, with over half of the US adults reporting at least one ACE and about 17% reporting 4 or more ACEs, is this Folletti and colleagues study that was published in 1998. And it established that there is a threshold associated with elevated risk for adverse physical, mental, and social outcomes in adulthood. And this landmark paper gave way to a myriad of other papers focused on the prevalence of ACEs in the general population. The proliferation of ACE research predominantly relies on comparative between group study designs that contrast racialized groups and document disparities. Existing research has documented racial disparities in ACE prevalence, with studies showing that Black adults experience higher rates of childhood adversity compared to white adults. And these comparative analyses often treat Black adults as a homogeneous group. While valuable for establishing population level differences, these approaches risk these approaches risk perpetuating a deficit narrative where they fail to contextualize race and ethnicity as proxies for structural factors that disproportionately disenfranchise racialized populations. When the disproportionate burden of ACEs among Black Americans are framed in comparative terms relative to white populations or other groups, such comparisons often risk oversimplifying the structural mechanisms that stratify risk within Black communities. And so when thinking about the antecedents of ACEs, I use the Racism in Health framework to guide my thinking. The framework was developed by Dr. David Williams and Selena Muhammad at the Harvard School of Public Health, and it displays the mechanisms by which racism can affect health. It outlines multiple pathways by which basic or fundamental causes can affect health. And so it indicates that in addition to biologic origins, social institutions, racism is also a fundamental determinant of health. And the model emphasizes the importance of distinguishing between basic causes and from proximal pathway. The framework establishes that while changes to basic or fundamental causes can lead to changes in outcomes, intervening at these proximal pathways without consideration for changes in the fundamental causes are unlikely to produce improvements in population health. So the pick boxes that you see overlaid represent components of my pathway of interest for my research, and they inform the conceptual model that I developed for my research, which is on the slide here, which has a similar pathway, and the research that I focused on is in the green box. And so with that framework in mind, and little to no within group analyses conducted among Black Americans, in ACE research, my research focused on exploring the prevalence of ACE exposure in this population. And so for this study, we used the 2019 Behavioral Risk Factor Surveillance System, also known as BRFIS. We restricted our sample to non-Hispanic Black adults who are 18 or older, and our analytic sample included 14,685 adults. And in addition to using the collecting demographic information from our sample, we also collected ACE measures, and that was part of a specific module, which I'll detail in the next slide. And so just a brief overview about BRFIS. It's a state-based cross-sectional telephone survey that's collected among non-institutionalized populations 18 or older. It collects data from states and jurisdictions of 50 states, the District of Columbia, and 3 territories. And the questionnaire has 3 components. The core component, which is asked of all states and includes demographic information, health-related conditions, the optional module. So each state has opportunity to determine if there are specific topics or emerging public health issues that they would like to include in their survey. And that's where we find the ACE module. And then there are also state-added questions that are not evaluated by the Centers for Disease Control and Prevention, and the responses are not made publicly available. And for the 2019 BRFIS module, it included those 10 ACE categories that were mentioned at the beginning of the talk, focusing on sexual abuse, family problems, family violence, and the sample, as mentioned, because states have to elect to add the ACE module to their survey. In 2019, there were 21 states who decided to include the ACE modules. We were able to collect data from those 21 states, primarily from states in the Midwest, as well as in the southern region of the United States. So this slide shows our table 1, where we were able to show the demographic characteristics for our sample. So we analyzed in aggregate both Black men and women, and then gender stratified. So we looked at Black men separately and Black women, and we found that Black women tended to be younger in our sample, more likely to be unmarried, have lower household incomes, and have a higher post-secondary educational attainment. And we found that most of the adults resided in a southern state. This slide looks at our weighted prevalence of ACEs, both among the aggregate and then among men and women. And so those 4 first blue circles you see are sexual abuse categories. The first 3 are individual questions about sexual abuse, and that 4th one is a combined question where we asked about forced touching in general, because there is a question about being touched and forced to touch someone. And so we see that there is a greater prevalence of among Black women for those questions compared to Black men. The orange circle, we see mental illness, where there's a greater proportion or greater prevalence of that ACE in Black women. And then the pink box at the bottom is for physical abuse, and that is reported higher in men than in women. So our next paper, our next analyses use the same sample. So we have the same 2019 sample, and we use the same indicators, but this time we applied latent variable modeling approach. And so I'll just pause here quickly to sort of note that the research that was shown previously was looking at individual level prevalence and also cumulative, and that's typically called a cumulative risk approach, where you're counting the number of ACEs that someone is reporting. And as a simple approach, it's commonly used in the literature, and it allows for ease of comparison. So I can conduct my study and then review other papers in the literature to determine how it compares in terms of individual ACEs. But as you can imagine, it weights each of the ACEs the same. And so some of the ACEs that have more adversity associated with them, the consideration is not taken as to whether or not one is more severe than another. And there's also little consideration for combinations or co-occurrence of ACEs. And so that's where the latent variable approach comes in and fills some of those drawbacks that we see in the cumulative risk approach, and allows us to look at clusters of individuals who are reporting similar ACEs, as well as estimating the association of those combinations with a particular health outcome. And the one drawback is that it is sample dependent. So the clusters and the classes that I identify in my 2019 data set might be different from someone else who's using a different year or a different data set. So after running our model and reviewing fit statistics to determine the best number of classes that fit both of our groups, we found a 3-class model was best suited for Black women, where we saw 2 high adversity classes, one where there was a higher endorsement of sexual abuse and one where there was a lower endorsement. So we see that about 17% of the Black women were in this high adversity without sexual abuse, and we see the forced sex and the unwanted touching have a low endorsement, and that's the light blue line. And then the green line is our high adversity with sexual abuse group, and that is about 13% of the sample. And those same forced sex and unwanted touching indicators now have a high endorsement probability. And then our third class is labeled parental disruption, but it's a low adversity class where we see a low endorsement on several of the indicators, with the exception of parental divorce, which is still relatively low, but relative to the other indicators, it's a little higher. We found that a 4-class solution best fit Black men in our sample, and we still see our high adversity with sexual abuse and low adversity without sexual abuse classes, but we do see that those percentages are lower. So if we focus on the green line first, that's our class 3. That's our high adversity with sexual abuse, that those forced sex and unwanted touching classes or indicators rather have a high endorsement. And then the light blue line, we continue to see high endorsement on several of the indicators, but not in the forced sex and unwanted touching. We still see a similar parental disruption or low adversity class that makes up about 67% of our sample. And then for Black men, we also see an emotional and physical family problems class, and that's about 20%, where we see the verbal abuse, high endorsement, as well as physical abuse. And that aligns with what we saw in our prevalence paper. And so the gender disparity we observed in the endorsement of childhood sexual abuse may be influenced by a variety of factors, including historical and contemporary social and cultural norms. Historical narratives of sexual victimization and contemporary hypersexualization and adultification of Black girls may contribute to the higher rates of sexual abuse experienced by Black women. This includes the codification of Black women's economic value for reproduction and the commodification of Black bodies during the transatlantic slave trade. The historical and cultural experiences establish the belief that Black women are prone to hypersexualization at an early age. For Black boys, they may be pressured to conform to rigid masculine ideas that prioritize toughness, emotional suppression, which can inhibit their ability to seek help or express their emotions in healthy ways. The higher endorsement of physical abuse among Black men may be influenced by societal pressures on Black men to conform to stereotypical notions of masculinity and may contribute to the higher rates of physical abuse. But by and large, this research helps us to understand and reminds us that we should reframe childhood adversity narratives as not as individual pathologies or parental failures, but really recognizing the role of environmental, social, and policy level determinants that shape adversity exposure. And so my research tells us that we know that Black Americans experience a disproportionate ACE burden. The literature tells us this within group sample sort of echoes that message, and also that ACE exposure is not homogeneous and that clusters do matter. But the current ACE framework, as we've shown, may be incomplete. And so the question is, are there other experiences that are missing from the ACE framework? As mentioned, the ACE framework was developed about nearly 30 years ago. And those traditional 10 ACE categories were typically household related or individual related. So they did not include community level adversities. And there is emerging scholarship that has proposed expanded ACEs, including witnessing violence, experiencing bullying, neighborhood stability, as well as racism and discrimination. But unintentional injuries have been largely overlooked as a formal category despite their potential to destabilize in early childhood development. So I included this slide because as we've now understand the collection of ACEs, specifically in Burfus and some of the 10 ACE categories, we see that many of them fall into this intentional injury category with a few that are not included, but there are events on the unintentional injury side that would warrant inclusion based upon how ACEs are defined. And so I included this map, which is the Injuries Control Research Centers funded from 2024 to 2029. The green box are those funded states. And then overlay are the blue stars represent in the 2019 Burfus those states that included the ACE module. And so those states include Iowa, Michigan, New York, Pennsylvania, and Wisconsin. And as mentioned, every year the combination of those states change, but I included it as given the importance of ACE surveillance and injury prevention and control, it's worth a discussion as to whether or not the ICRC should advocate for the ACE module in the respective states. And I also wanted to note that the National Center for Injury Prevention and Control released their fiscal year 2021 to 2024 ACE prevention strategy. And that strategy included 4 goals, but it aligns with the research that I've presented thus far and some that I am proposing. So the first goal is supporting the surveillance of ACEs and data innovation to guide the ACE prevention, identification, response, and evaluation efforts, and focusing on the surveillance to help understand the scope of the problem, where ACEs are likely to occur, who is at greater risk of experiencing ACEs, and some of the social impacts. And so I think that some of my earlier work speaks to that goal. And then the second goal focuses on the expansion of the ACE evidence base by conducting and supporting innovative research and evaluation. And that includes thinking about opportunities for expanding our understanding of potentially traumatic experiences that can be considered an ACE, thinking about linkages between ACEs and other forms of injury and violence, which aligns with some of the work that I'll be sharing going forward. So when I thought through potential candidate unintentional injury events, I made sort of a short list that of unintentional injury events that are worthy for consideration, primarily based upon thinking about the mechanisms of destabilization, because it's a key component to thinking about something that might be classified as an ACE. And so the first one is the accidental death of a parent or a caregiver, and some of the mechanisms of destabilization that might contribute to that would be the loss of a primary attachment figure or potential household economic collapse. Having a house fire, experiencing a house fire, and having that acute trauma, which may result in displacement or the loss of a safe environment. The experience or exposure to someone who might be involved in a motor vehicle crash, and thinking about the physical injury, potential loss of a family member, and financial strain that might come as a result of that event. Near drowning events, which can be a acute life threat and have potential neurological sequelae and result in caregiver trauma. Thinking about events related to accidental poisonings and the caregiver guilt or dysfunction and potential household instability that might result. And then severe burns, and thinking about the long-term medical burden associated with experiencing a burn during childhood, social isolation, and body image. So this slide is just a crude way of thinking that I've been thinking about how an unintentional injury event might sort of fit into a similar category as an average childhood experience. So thinking about that acute trauma response, and then thinking about sort of the bifurcation of household destabilization and some that were mentioned in that previous slide, financial stress, impact to caregiver and potential displacement, but also neurological disruption, and thinking about the toxic stress pathway and dysregulation that might come as a result of that event, and then thinking about moving through the toxic stress pathway and having an ACE equivalent health outcome, whether it be related to a chronic disease, a mental illness, or premature mortality. So I included this excerpt from Andrew McGuire, who is an injury control advocate. And in his paper, Fires, Cigarettes, and Advocacy, he recounts the human devastation that is not always captured when discussing the economic burden of fires. In the excerpt, it focuses on 6-year-old Mary, who was severely burned in a fire and tragically lost her parents. And it also recounts how she witnessed the loss of fellow burn patients while receiving treatment in the trauma center, and the emotional trauma and physical pain that as a result of these unintentional injuries make it clear that they constitute adversity. So this is an outline of how I thought through my proposed research plan in terms of starting off with getting a landscape of the surveillance landscape and through the means of a scoping review, and then thinking about those candidate events and establishing prevalence rates and patterns, and through a secondary data analysis, psychometric measurement, and thinking about potential scale development, and then ultimately evaluating the association with health outcomes. And so for the purposes of this talk, I will focus on the scoping review and give a few points at the end about some of the other parts of the research plan. And so for my scoping review, I knew that unintentional injury surveillance and ACE surveillance were tracked in separate systems. The systems were built for different purposes, and they often rarely communicate. But no study has examined systematically whether unintentional injury events are captured in the ACE infrastructure and vice versa. And this can create a fundamental data gap that prevents us from being able to estimate the scope of the problem. And so some of the relevant questions were what unintentional injury events are currently being tracked, and what ACE relevant data elements exist in those injury databases, and where do injury and ACE surveillance systems overlap. So this is just a summary of my methodological approach in terms of thinking about those systems, the information, the questions that are being collected, as well as the variables that are being collected, and the injury type whether or not there's information about household or family context, and whether or not it's child specific and has information that can speak to an ACE experience or childhood experience. So this slide has a lot of text on it, but I included it just to sort of highlight some of the inclusion-exclusion criteria that I use when thinking about the myriad of unintentional injury surveillance systems and ACE surveillance systems. So I focused on nationally or federally administered surveillance surveys or administrative databases. I focused on US-based systems and systems that collected data from children ages 0 to 17, or from adults and they with retrospective data collection. I focused with regard to injury on systems that were collecting unintentional injury, both fatal and non-fatal, including motor vehicle crash, fires, drowning, poisonings, falls, and burns. And then for the adversity context, focusing on systems that collected ACE items, including household-related experiences and trauma exposures. I focused on systems that were publicly available or accessible through a data use agreement and that were currently active with data at least 10 years retrospective, and then focused on surveillance systems that has sufficient documentation where I could evaluate the methodology and the sampling approach and that were in English. So this is a list of the unintentional injury surveillance systems that I included as a preliminary on my list. So the first is the web-based injury statistics query and reporting system, the WHISKERS, that is administered by the Centers for Disease Control and Prevention. And it's an interactive CDC database focused on fatal and non-fatal and cost of injury data. It does have some child-specific information, and so I included it as a yes. I also looked at the National Electronic Injury Surveillance System that is maintained by the Consumer Product Safety Commission. It's a probability sample of hospitals that's collecting information from the emergency departments on a particular consumer product on poisoning, and focuses on children who were younger than the age of 5. So I listed that as a yes. The National Violent Death Reporting System, and thinking about the information that's collected as a part of that system, that they have information on child victims and information on caregivers, household, previous contact with Child Protective Services. So there is some information related to the child depending on what we're looking for in analyses. There's also the Fatality Analysis Reporting System, and that's maintained by the National Highway Traffic Safety Administration in the Department of Transportation. And that specifically collects child-specific data, such as age of the child, the restraint used in the vehicle, and seating position of the victims who are 15 and under, if it is a fatal motor vehicle crash. But it's not a comprehensive child database. So I listed that as partial, where there is information, but it may not be sufficient. And then lastly, I listed the National Fire Incident Reporting System, which does collect, does not collect specifically child information, but does have some data on juvenile fire involvement and tracking trends. When I thought about the ACE datasets, I wanted to know whether or not there was data collection on unintentional injury events that are experienced by the child or the caregiver. So we've talked about the birth as ACE module, very limited questions. In that survey, there is an optional module that states can include that's focused on falls, firearm safety, and seatbelt use. But again, it requires the inclusion of those questions in a survey for us to have the information to analyze. Pardon me. There is the National Survey on Children's Health, and that's maintained by HRSA, and it does have some injury-related events on concussion or brain injuries, including schools and missed days and other functional limitations that may be related to an injury. There's the Adolescents to Adult Health that's maintained by the National Institutes of Health that has some data, covers injuries on motor vehicle crash and physical activities. And then the longitudinal study for child abuse and neglect, the LongScan study at NICHD, has some limited information, again, on poisonings and burns and other physical injuries related to children. And then lastly, the National Survey of Child and Adolescent Wellbeing that's maintained by the Administration for Children and Families. And that collects injury information alongside some other threats. But again, it's not the primary focus of the surveillance system, and it's more related to the engagement with Child Protective Services. So these are just some of the initial findings and summaries based upon the work that I've done thus far. I just identifying that there are parallel silos, so the unintentional injuries and ACE surveillance systems have different infrastructures, and there are really no formal linkages established as of now. And then when we think about the surveys that were listed in those previous slides, the National Survey for Children's Health represents one of the ACE surveillance instruments that does capture injury-related adversity. The question is about a serious accident or injury. However, it doesn't provide the level of specificity with related to the unintentional injury about a serious illness, and it doesn't distinguish the injury type, doesn't collect information about household disruption or caregiver impact. So there's additional information that, while useful, would be helpful for us to understand that's currently not there. I found that the most severe gap, or where we didn't see as much information, was about accidental parental death. And so the FARES and the NBDRS do capture adult accidental fatalities, but no database systematically identifies information about the surviving minor or tracks the outcomes for those children, because we know that from the literature that it's well established that parental bereavement is a profound ACE experience. And then lastly, the best covered candidate ACE candidate unintentional injury ACE was the motor vehicle crashes, based upon reviewing the surveillance system. So there's coverage in the FARES, the fatal crashes, there's non-fatal and fatal data in the whiskers. There are also databases focused on trauma admissions and pediatric hospitalization that allow us to collect information. But again, none of these systems, and they're not in, they were not developed to do so, capture household instability, caregiver mental health impact, and some of the psychosocial outcomes that would be needed to sort of classify and provide more context for MVC as a ACE equivalent experience. And so as mentioned, I'll just briefly talk about some of my thoughts going forward for the rest of this research. And so being able to leverage nationally represented and data sets is helpful, but I think being able to understand the number of events that are happening in both data sets, so thinking about the unintentional injuries as well as the ACE data sets to really get a sense. And then if there is a way to sort of be able to capture those candidate events, being able to know the frequency of those, and also the co-occurrence. So as mentioned, typically ACEs co-occur. They don't just, you typically just don't have one. And so while it's useful to know which individual ACEs are taking place, understanding how they co-occur with the 10 original ACEs, but also with each other is helpful. And then thinking further down the line about psychometric development. So item generation through thinking about injury-related trauma items that are in validated studies, and convening expert panels, both with researchers, clinicians, as well as community members, and conducting cognitive interviewing with diverse samples to get a good sense of how best to represent them in a survey. And so I'll just conclude by saying a few things. The ACE framework has evolved, and unintentional injuries warrant consideration as part of that evolution. ACEs have been expanded to include community level exposure and systemic levels of oppression and discrimination. And each expansion has been met with the same question: does the experience disrupt the child's sense of stability, safety, and nurturing? Does it activate the body's stress response pathways? Does it produce lasting harm? And I think it's fair to say that unintentional injuries, the ones that have been identified in this presentation, answer yes to some, if not all, of those questions. And so the framework has evolved before, and it's worth considering evolving and including unintentional injuries. As mentioned, these unintentional injuries as an ACE in its full scope are unknown. I think we have data from different surveillance systems, but being able to capture the event and then some of the household and social impacts are not known yet. So that is sort of a natural next step. And then we've seen from the excerpt about the house fire, as well as the way we know individuals experience different types of ACEs, that how we measure ACEs matter. So understanding the counts and the frequency are useful, but also understanding how they co-occur and clusters and patterns are useful. And then lastly, the inclusion of unintentional injuries as an ACE allows us to understand how unintentional injuries can contribute to chronic disease and mental disorders, and allows us to conduct that last step in the plan, which is thinking about an association between health outcomes. So with that, I appreciate your attention, and I thank you for the opportunity to share my work with you, and happy to answer any questions.
Thank you, Dr. Oyedele, for a wonderful talk, the impactful topic. And we would like to open it up now for question and answer. You can either enter your question in the Q&A section at the bottom of your screen, or you can raise your hand to ask a question. And when called on, we will allow you to turn on your mic and video to ask a question. Well, I have a question while people are getting their thoughts together. In the future, if we were able to include injuries in ACEs surveillance comprehensively, how do you think this will change prevention or response efforts?
I think the hope is always that it's able to directly impact and so provide a solid foundation of how to prevent or mitigate these events, and also inform policy. I think that one thing that I'll add to your question is that, as you noted, there are some ACE surveillance systems where that is the primary focus, some of which I did not mention, and some of which it's included sort of as an option. And I think that in addition to the question that you asked in terms of collecting it and being able to prevent and mitigate risk and sort of understand if we see a health outcome, if there is an event that's related to that, making sure that our collection is sound in terms of always collecting that information and not having it be an optional means. And I'm specifically talking about BRFIS, but I think that if it's important and if we know that it is important to study, I think strengthening the way in which we capture the information is important, and it's a good start.
Thank you. And we have another question in the chat, and then I'll go to the hand raised.
Yeah.
Are there ACE questions on the YRBS surveys?
They are, yes. So there are ACE questions on the YRBSS. And so that's an example of a survey that specifically focuses on ACE collection. And so that's one that I didn't necessarily include, but it definitely is worth consideration. And it is specifically focused on youth. And so it addresses some of those goals of having a more proximal response to an event. So when an event is happening, you're asking someone in their child or adolescent phase versus having someone think retrospectively about the particular ACE. But that is definitely an ACE specific surveillance survey that is should be included. Yeah.
And Chanel?
Hi.
Hi, how are you?
Oh, I'm well. How are you?
Thanks.
I am a grad student from the University of Michigan. I wanted to ask, interested in researching similar things, and also from the experience of a younger Black woman, I'm wondering what your perspective is on maybe differences in generations, and with like culture and social media. What do you think is a way that we could intervene so that the cycle stops getting reinforced? I don't know if that makes sense.
Can you ask your question one more time?
Yeah. What are some ways you think we could intervene in the sense of like how the cycle is reinforced through different like mindsets across generations, across
Sure.
like, yeah.
That's a good question. I think giving the context and the knowledge. So let me answer it like this. This came up when I thought about physical abuse. And so a lot of my research went into, thinking about why it's happening. I think I gave some context, but also sort of the historical context of that abuse. And I think that it can be two-sided in terms of people seeing it as a benefit or not considering it abuse, thinking of it as more of a correction to sort of support that person that young child, as they prepare for a world that may be unkind or may be harsh. And so being able to sort of put each of those in a context and also educate across generations to say that, these things happen. And I don't think it's, again, fair to say that it's a parental failure or, a specific pathology, but it is in the context of the world in which we live in. And so the way that these people, the way that individuals experience these ACEs, sometimes the way they manifest are a result of the structures in which we live in, and really trying to help people understand that, while also trying to help them to understand the harms associated with, if they are conducting that behavior, how it might impact their children, or it might have impacted them, and then it's continuing through the generations in the way that they're rearing their own children.
Thank you. Carrie?
Natasha, thank you so much for a fantastic presentation and very, very interesting work. I had a question about, I was kind of curious about why you left, you didn't include occupational injury as part of your work.
I don't think that was intentional. I think that it definitely... So I know that at least for Burfus, there are some questions that you can include, and I think it's worthy for consideration. So I think those 6 candidate events are not set in stone. And I think that depending on the information that's found and sort of the way in which we contextualize that sort of mechanism for destabilization, it is a worthy for inclusion. But it wasn't an intentional exclusion of occupational injury.
Okay. There are some national data sets that cover occupational injury, both fatal and non-fatal. Yeah. Mm-hmm. So it could be, I don't know if they would have, and probably likely don't have anything that's ACE related, but but definitely something maybe to consider.
Yes.
Thank you so much.
Thank you for that question. I appreciate it.
Thank you. Another one in the question and answer says, sorry if I missed this in your presentation, but do unintentional firearm related injuries, playing with a firearm and accidentally shooting oneself fall under the UI umbrella that you consider for expanding ACEs, especially with firearms being the greatest cause of youth mortality in the US? And if so, is there an opportunity to collaborate with groups doing work to mediate those injuries?
Yeah, so the first part is yes. That would be included in the unintentional injury ACE, and I definitely think that the second part was about collaboration. I can't see the questions. I apologize.
I'm sorry. Yes, and if so, is there opportunity to collaborate with groups doing work to mediate those injuries?
To mediate the injuries?
Mm-hmm.
Yeah,
maybe to mitigate the injuries. Oh. Yeah, same.
Okay, so like to mitigate the risk of the injuries? I think so.
Yeah, I wonder if Helena, if you want to just turn on your volume and share, or... I think that's the essence of the question.
Yeah.
There we go.
To unmute myself. It just let me. I'm sorry if my question doesn't make sense. I just I had to join a little bit late, so I'm sorry if I missed this in your presentation. But I was just wondering about I hadn't caught unintentional firearm injuries in the I think in the surveillance systems you were talking about, and so I was wondering if that was involved in the expansion that you were considering. So that's good to know.
Yeah.
Just thinking about firearm related injuries, like a lot of youth, like playing with firearms that are in the home, like finding them, like if they're not stored properly, or if they are stored but they're not like secured properly. Thinking about like groups that are working to mitigate that, not mediate that, but mitigate that or reduce the risk of that. Just thinking about, are there ways to get those groups on board with assessing youth who could be at risk, if that makes sense.
It does. Yes, it does. Thank you for your question. It does. And I think that when we think about, so firearm use, I definitely would consider that as well. And I think that there's a place for it in terms of thinking about witnessing that experience, whether it's in the household or being a victim of gun violence. And I do think that when we think, thinking down the line in terms of some of the proposed research involving the community, but also thinking about establishing the prevalence to be able to talk through what that might look like on its own, and then maybe in relationship to other health outcomes. So I think that there is a place to involve the community and those who have that lived experience as a part of thinking through the framework.
Thank you.
Thank you very much.
Any more questions? Did that answer your question?
Sorry, I wasn't unable to unmute myself. But yes, thank you so much. Thank you.
Great. Well, we would like to thank you again, Dr. Oyedele, for your presentation. We would like to thank our collaborators for the partnership, and we hope that you all will join us again for our next session. Have a great day, everyone.
Thank you.